Good morning and welcome to the hepatitis C session. Each communication is expected to last about 20-25 minutes, including questions that every speaker would answer to after his speech. So after so many years waiting and so many years of trouble, we are finally entering into a new era of the hepatitis C treatment. Interferon and ribavirin give their way to real and antiviral agents which could eradicate HCV without regard on the patient's genotype. A revolution started now. Let me introduce the first speaker, Fabien Zoulim, who is professor at Lyon 1 University, director of the Department of Immunology and Virology of INSERM unit, and a governing board member of the European Association of the Study of the Liver. Now, Fabien Zoulim is going to present the new anti-HCV agents in the pipeline.
Okay, thank you for the introduction. Good morning to everyone, and I would like to thank also Alain Lafeuillade for the invitation here in Marseille. So I will try to give you a short overview of the drugs that are now in the pipeline for HCV therapy. Here you see my conflict of interest. And the title of the session is really up to date because we are really living a revolution currently with the treatment of hepatitis C, and you know that the major progress have been made in that field since 25 years now. Since 25 years ago, we had only standard interferon available, and we could cure only 5 to 10% of the patients. And with all the progress that has been made, and now with the development of new direct-acting antivirals, we may reach a cure of HCV in almost 100% of patients without interferon therapy. So how could this be made? This has been made possible because researchers have been really involved in the understanding of the viral replication cycle in the molecular biology of the virus. And I won't go through this in detail, but this work has allowed to decipher the different steps of the RNA replication inside the hepatocytes, which allowed then to identify targets for antiviral therapy. And these targets are represented here in a schematic fashion. You have entry inhibitors, you have strategies to interact with viral RNA as well as host factors using RNA interference. You have drugs that interfere with the translation of the viral protein, mainly IRS inhibitors. And then you have these more direct acting antivirals targeting the replication machinery of the virus with protease inhibitors, helicase inhibitors, NS5A and polymerase inhibitors. And these are really the two main targets that are developed now in the clinic. Host factors also have been developed as targets like cyclophilin, and there are some cyclophilin inhibitors that are still on clinical evaluation, as well as assembly inhibitors, and drugs also or strategies to interfere with the immune response and try to restore immune response against HCV infection. Now, when you're thinking of direct-acting antivirals, which are now being available now in the clinic, you know that with monotherapy we won't be able to reach a cure, and this was the concept was well known because this is a very dynamic virus with a lot of viral heterogeneity, and it was shown with the first generation protease inhibitors like telaprevir or the others, that with monotherapy you can select for drug-resistant mutant within 2 weeks of therapy, and the quasi-species completely change from a major wild-type strain to the emergence of many resistant mutations just after 2 weeks of therapy. So clearly monotherapy is not the way to go for HCV. And then there were some interesting observations that were done approximately at the same time, that in vitro, if you combine direct-acting antivirals that are targeting different steps of the viral life cycle, for instance, a protease inhibitor and a polymerase inhibitor. Here you see results in a replicon system, that if you're increasing the dose of both drugs, you will see that the number of colonies that replicate the HCV is decrease, and in the end you can achieve viral eradication from the infected cells in tissue culture. So that was the concept. And then to go for combination therapy, we needed to know more about the target, so the viral protein. So now it has been very well characterized. The viral polyprotein is processed in different structural and non-structural proteins. So the structural proteins are the core and the envelope E1 and E2 proteins that represent the assembly module of the virus. And you have all the non-structural proteins, and mainly the protease, NS5A and NS5B, which is a polymerase, which represent the replication complex. And for these, all these proteins, the 3D crystal structure is known and characterized, and all the function has been also characterized. So this allowed to really develop drugs and screen drugs for all these proteins, and mainly the ones that are involved in the replication of the virus. So this has led to mainly 3 big classes of antivirals, or of direct antivirals. So the protease inhibitors that are called Previr. So you have telaprevir, boceprevir, and so on. So it's easy to remember. So the first wave, first generation PIs are telaprevir and boceprevir that have been approved now 3 years ago in worldwide. There are new drugs coming, which are still from the first generation, but are second wave. What we call second wave is these drugs that have been improved in terms of safety, mainly. So simultaneous, which is being approved now, and many others, as you can see here from different companies. And you have also second generation protease inhibitors, which are supposed to be not only more safe, but also to cover more genotypes, because all these were mainly targeting genotype 1 virus. The second generation are supposed to target more genotypes. So here you see the structure of the protease with the active site, and where all the drugs, depending on their structure, whether they are linear or macrocyclic, will interfere in the enzymatic active site. And you see here just quite an old diagram of the cross-resistance profile, and you see that for some mutation you have quite a broad cross-resistance profile, which means that some protease resistant mutations will confer drug resistance to all the class, which is maybe a problem in the clinic. You have the NS5B inhibitors, so the polymerase inhibitors. So since NS5B, so these drugs are denominated buvir. So you have sofosbuvir, lomibuvir, and so on. So you have two different classes of polymerase inhibitors. You have nucleotides analogs, and the most famous one is sofosbuvir. And you have non-nucleoside analogs with different subclasses of drugs. when you look at the HCV polymerase inhibitors, you see here the 3D structure of the viral polymerase with the active site here, where the nucleoside or nucleotide analogs will really interact with the active site and try to inhibit the incorporation of new nucleoside in the nascent viral RNA chain. And you have also the non-nuc, which will interfere at different sites of the polymerase, but outside of the active site. So you have different classes, and we may play around with these classes to inhibit viral replication. Regarding sofosbuvir, which is now available in France, it's acting as a RNA chain terminator, because this is a nucleotide, so it will be incorporated in the nascent viral RNA chain and will terminate the RNA synthesis, so no more nucleotides will be incorporated in viral RNA, which will explain the inhibition of viral RNA synthesis. So what is interesting with this nucleotide analog is that it's pangenotypic, it's active against all genotypes, and it has a high barrier to resistance. So it's quite a good drug as a backbone for combination therapy. So besides the protease and polymerase inhibitors, we have also the NS5A inhibitors, since we have NS5A, so they are called ASVIR. So you have the famous daclatasvir, for instance, and all the others. So we have also 2 generations of drugs. So we are obviously in the clinic dealing with the first generation. And we have the second generation of drugs which are now being evaluated in the clinic. And these drugs are supposed to have a broader coverage of viral genotypes, which is an important feature of these future drugs. Here you see again the structure of this of NS5A and how, for instance, daclatasvir is interacting with NS5A and the possibility of resistant mutations, obviously, for all these drugs. So now if we try to consider what is important towards a drug or combination of drugs that will really help to cure most patients, and so that we could develop what is generally called in a fashionable manner a perfectovir therapy. So what you want to have is drugs with high efficacy, broad genotype coverage, a very good resistance profile, no adverse events, and very few drug-drug interactions. So when you look at this, you see that the nuc have a very good profile on all these criteria. So they are in green here. And you see that depending on the class of drugs or their generation, first versus second generation, you see that we may have the rationale to combine, for instance, a nuc plus an NS5A and so on, so that we really do the best to tackle HCV replication. And you see here also that the protease inhibitor of the first generation, which were quite good because we had nothing else to propose to patients, are not that good in the perspective of eradication of the virus, at least if they are not in combination. Now, what can we do in terms of interferon-free strategies? So we have many drugs, different class of drugs, so we can combine them in a rational manner to eradicate the virus and prevent drug resistance. So one first combination that can be made, and this is obviously can be done either internally for all the drug companies. They try to have their own combination, but we could also, as clinicians, try to think of combining the best drug of one company with the second drug of another company, and we hope that we will be able to do that, which is not true actually in the future. So first combination that you can do is a nuc with an NS5A inhibitor, plus or minus ribavirin. Another combination that you can do is using a non-nucleoside inhibitor, and since these non-nucleoside inhibitors have a lower barrier to resistance, you need to combine more drugs, so a 5A inhibitor plus a protease inhibitor and ribavirin. You can be brave enough to say, well, if I have a non-nuc, I want to still to get rid of ribavirin and combine only protease and inhibitor and 5A inhibitor. And then there's other possibility is to go for the second generation of drugs, which have a better genotype coverage and a better barrier to resistance. So trying to combine, for instance, a second generation protease inhibitor with a second generation 5A inhibitor. So I will try to not to show you all the possibilities, but try to also to show you what we can do to answer clinical questions. So one of the questions is whether we can go to even shorter duration treatment. We were with 1 year therapy with interferon ribavirin. We went down to 6 months, so 24 weeks with sofosbuvir plus ribavirin. And now can we do better 12 weeks or even 8 weeks? So there are different combinations that have been studied in that respect. And you see here a combination of ledipasvir, so an NS5A inhibitor, plus sofosbuvir, the nucleoside analog, plus or minus ribavirin for 8 to 12 weeks. And you see here here in pink and blue the 8-week therapy. And the SVR rate, which is excellent, and is doing as well as a 12-week. So in theory, at least for patients who are non-cirrhotic and naive, we could propose this type of combination for only 8 weeks. So this is really something, a big improvement. You see that it works very well with this combination, so ledipasvir plus sofosbuvir. And now there are drugs from other companies that are being tested, protease plus NS5A inhibitors, both of second generation. And they tried to do it for 8 weeks. And for 8 weeks, even with ribavirin, it didn't work that well compared to the 12-week therapy. So clearly, all regimen will have to be evaluated in a very careful manner before going to shorter duration treatment. Although, 80% looked very well 3 years ago without interferon, but now the bar is very high. We would like to achieve 95 to 100% eradication. Now, difficult to treat populations, cirrhotics. What can we do in cirrhotics? You see again the study with ledipasvir and sofosbuvir, and you see here they were very cautious. They did 12 weeks versus 24 weeks. They didn't go for 8 weeks in cirrhotics. And you see here that we can achieve almost 100% eradication, whatever the fibrosis stage in patients, whether we do 12 or 24 weeks of therapy. Now here it's the study from AbbVie with the non-nuc inhibitor plus protease plus NS5A inhibitor. And you see that in cirrhotics with genotype 1b, 12 weeks or 24 weeks look quite the same. But for genotype 1a, so depending on the subtype, you may have some differences, because here with 12 weeks you have only 88% SVR. So in cirrhotics, genotype 1a with this combination from AbbVie, a 24-week therapy would be recommended. I will just skip that one. And you see again the other combination from Merck with the protease and NS5A inhibitor from second generation. And you see that they've tried 12 weeks versus 18 weeks in cirrhotics. They are very cautious. And you see that you can achieve quite a good SVR rate in these patients, whether you do 12 or 24 weeks. Now, patients in treatment failure, they have, can be in failure of PEG-ribavirin or even in a failure of protease inhibitor-based triple therapy. So several studies have addressed this population of patients. So ledipasvir plus sofosbuvir for 12 or 24 weeks. And you see that there was no difference. We can reach very high rate of SVR, whether they failed dual therapy or even triple therapy. So that's quite good overall. But now if you look at the subgroup of patients with cirrhosis, you see that if you do a treatment for 12 weeks, then the SVR rate declines. So clearly for patients who are cirrhotic and failed previous therapy, the treatment with ledipasvir and sofosbuvir will have to be prolonged for 24 weeks to provide maximum chance of eradication. So the same is true with the AbbVie combination. I won't go through all this, but it's just to show you that even in this population of patients, we can reach very high SVR rates. So we can achieve a cure of patients, even in those who were difficult to treat. The same for the Merck study. Now, a very difficult population, the decompensated cirrhotics. We know that in these patients, interferon is completely contraindicated. There are very few studies in that population. And here, it's again a combination from Gilead with sofosbuvir and ledipasvir in a fixed dose combination. So patients with severe cirrhosis, and you see here that only 2/3 of the patients have an SVR after a 12-week therapy. So really we'll need more studies and with newer combination therapy, maybe we should go to 24 weeks or to go with better drugs. So here in that situation, there are still questions in these patients. Recurrence after liver transplantation is also something very important because in this case, the disease progressed very rapidly. And here you see the combination of AbbVie of a non-nuke plus an NS5A plus a protease inhibitor. It was an open label study for 24 weeks. And you see here the SVR rate on a small number of patients, but still very impressive, 96% SVR in this very difficult to treat patient population. So here again, we can provide some answer to the patient. And now to finish the presentation, can we go for a single combination that would work on all genotypes? So that would be the dream for the physician, because it would be very easy. So we could have the same for everyone. So several combinations are currently being studied. Here you see just a combination of an S5A protease inhibitor and a non-nuke from Bristol Myers in genotype 4, naive patients, and you see that after 12 weeks of therapy, they can achieve very high SVR rate, cannot do better, but only on a small number of patients. So we need to do more studies in the genotype 4. Genotype 3, which was quite easy for PEG-RIBA, is not that easy for the new drugs. And you see here the results of sofosbuvir plus ledipasvir in patients with genotype 3. So if they're treated only for 12 weeks, only 2/3 of the patients will have an SVR. If they are treated for 12 weeks with ribavirin, 100% of patients will be cured. So again, the combination will depend on the genotype as well as the duration of treatment. So we are still some adjustment to do, and we don't have the magic combination that could be applied for everyone and to be the same for everyone in each situation. And there's a new NS5A inhibitor from Gilead. So that's a second generation NS5A inhibitor that is combined with the nucleoside analog, sofosbuvir, without ribavirin. So it's a very simple combination, just two drugs, a nuke and an NS5A inhibitor. And since it has a broad genotype coverage, they studied in all genotypes, genotype 1, 3, 2 to 6. for 12 weeks. And you see here the very high SVR rate. And you can see here the across genotypes and dosing. With the highest dose, you can achieve very high SVR, even in genotype 3. So clearly, these new generation drugs are providing even new hope to have a broad coverage. And this will come very fast. Within a couple of years, we should have them available. So this is providing really new hope for patients. And I will finish with global questions in perspective. So we can provide true cure of HCV infection, and we are really living a therapeutic revolution with these interferon-free regimens. As you've seen, there are still several difficult-to-treat populations, failure of PI-based triple therapy, the genotype 3 cirrhotic patients, the pre- and post-transplant patients are still difficult. Drug addicts with treatment with substitution, HIV co-infection that will be addressed now with the issue of drug-drug interactions. And there are some questions for the difficult-to-treat population on treatment duration, the role of ribavirin, and in the few patients who will not have a SVR, will multi-resistance be an issue? We don't know. And in terms of global questions, there are really important questions regarding patient screening, treatment access, organization of medical care to manage the patients, and the cost of therapy. And it's quite good that we have competition, so that we hope that the competition will allow to really cut down the price so that we can provide treatment for everyone worldwide. Thank you for your attention.
Thanks, Fabien, for this very exciting presentation. Right now, the session is open for discussion. Yes, microphone number 3.
Thank you, Fabien, for this very nice presentation. I would like to know if it is still necessary to monitor the viral load at the beginning of the treatment. What is the predictive value of a rapid relapse of viral load? Is it necessary to do that?
For instance, there has been a quite extensive study for the sofosbuvir trials to see, because there are quite a high number of patients that have been treated, to see whether the early kinetics of decline of HCV RNA could predict the few relapse. And unfortunately, at the individual basis, you cannot predict this relapse. So the viral load monitoring, I think we need, because it's starting, so we need to do it so that we can make sure that the patient adhere to treatment, and it will be very important. Treatment observance will be very important, but to predict the subsequent failure, currently it didn't prove any added value for that.
Thank you.
Fabiano, very nice presentation. In some of these studies with potent direct-acting antivirals, after being with undetectable viremia for 2 months, even 3 months, there is a relapse. What's your opinion? So there is some low level of escape viral replication under this prolonged undetectable viremia, or is some compartment that can hide the virus there?
Yeah, I think thank you for this question. It's very, very important because we are very enthusiastic. We show this 95% and SVR, but for those patients who are cirrhotic, who have been in failure of, for instance, protease inhibitors-based triple therapy, for those few patients who will relapse after these new treatments, the question is, what are we going to do? Because what we see in these patients usually when you do sequencing is the presence of NS5A or protease-resistant mutation. Sometimes they can be on the same genome. So the question will be, do we have multi-drug resistant mutant? and how we're going to manage. So regarding the understanding, we don't know because it's very complex because during treatment, the viral load is undetectable. So it means that the virus persists somewhere. Is it in the liver, just in a random manner, or is there a specific reservoir for that? I think we need to do more studies, but it would need to have access to the liver, or to PBMC, or to some other compartment. So it means that we will need to biopsy some patients, but we need to identify, predict those who will relapse. But as we said just before, there's no predictive factors for that. So it will be a very difficult question because we don't biopsy the patients anymore for HCV. And to answer this type of question, we need to have access to the liver to do more studies.
Thanks, Fabien. I have one or two questions just before you leave. Regarding the concept of second wave or second generation of drugs. So you described that the second generation is based on genotype coverage, but also on resistance profile. But even this drug is not completely effective against mutants or all the genotypes, and we have to combine these drugs. What is your opinion about it?
Well, I think currently the concept is that we will need to combine these drugs. I mean, unless we had an improved sofosbuvir, for instance, which could make it because it has a wide genotype coverage, high barrier to resistance, but it's not as potent as we would like, I believe. I mean, we need to have a more potent sofosbuvir. Then you could have a single drug. You know?
Yes, but
like we have with for HBV with tenofovir, for instance.
Yes, we saw that we have a very exciting drug in HIV. So like this is a dolutegravir that we do not observe any resistance in vivo. And right now with sofosbuvir, we only observe one case on resistance due to a low viral fitness of these drugs. But when you present on the last data on the relapse, did we observe new resistance in these patients or not, or only the only case that we know?
For sofosbuvir, so far, not. I mean, just from what we have seen so far with the relapse of sofosbuvir, just one single case with the S282T mutation. All the others are associated with wild-type virus. The problem is that you could imagine that if they relapse, it means that the virus was still there, maybe in the liver, most likely in the liver. So you could imagine that you may have some drug-resistant mutants that are less fit, so they cannot emerge during therapy, so you don't see them in the blood circulation. And when you stop treatment, viral replication start again. But since you have released the selective pressure, then the wild-type virus comes back as a major strain because the other one is less fit. So it will be very difficult, unless we have access to the liver sample to do some sequencing there, so to do ultra-deep sequencing. It will be very difficult to show that what is happening. Is it just a problem of pharmacology of the drug that we should maybe treat longer? That would be the easiest in the clinic. Or is there really resistance?
Okay. Thank you very much, Fabien, for this presentation. So right now it's with a great pleasure that, and we're very proud to see Professor Vincent Soriano. He's the chief of infectious disease and hepatology in Hospital Carlos. I know that in Madrid. And so thanks for also your great contribution for the science in the field of co-infect patients. And because all your papers are very important in this field. And thanks for your coming.
Merci Philippe. Je vais vous remercier et aussi professeur Alain Lafeuillade pour l'invitation à venir ici. It is always a pleasure to be in Marseille and in this meeting. I have been here for several years, and the task I will address this morning is the advent of the arrival of these direct-acting antivirals for hepatitis C and HIV. So these are my disclosures, and just 2 months ago in Geneva was a meeting that tried to focus and update the numbers of people with HIV and different viral hepatitis infections, and I think this is the most recent figures for monoinfection and for co-infection. So they reduce a little bit the numbers we have plaguing for a while, and for hepatitis C, people with viremia for longer than 6 months, which we call chronic hepatitis C, the numbers worldwide are around 150 million. That means that in terms of seropositive for hepatitis C is 180 million, more or less, so 25% spontaneous clearance. For HIV, people living with HIV right now is 35 million, and for estimated co-infected individuals will be around 15%, so that will be around 4 million people worldwide. As you can imagine, when we address specific populations, intravenous drug users in Russia, in Southeast Asia, in the east coast of the US, or several years ago in Southern Europe, including France, Italy, and Spain, probably these figures are higher. For example, in intravenous drug users in my city, in Madrid, was more than 70% with chronic hepatitis C, like in hemophiliacs, more or less. So, but really, intravenous drug use has been going down for the last decade, and we no longer have incident cases, significant incident cases of intravenous drug users. Totally different story in Eastern Europe, including Russia, Ukraine, and Southeast Asia, especially in Vietnam. For HIV, and those familiar with HIV, it is very clear the benefit of antiretroviral therapy. It starts with sustained viral replication, but it moved to major clinical benefit, improving CD4 counts. This benefit also translates in less immune activation and less persistent inflammation. That means less cardiovascular risk, less neurocognitive dysfunction, less organ body system dysfunction, renal, hepatic, everything. There is also less transmission when the index cases have undetectable viremia, and really drug-related toxicity is the only disadvantage right now. We treat almost everyone with HIV. The only exception are elite controllers and long-term non-progressors, but really with the current antiretroviral armamentarium, we treat almost everyone. And the only cost we need to pay, in addition to money, is long-term side effects, kidney toxicity, bone demineralization, all these issues you are very much familiar. For hepatitis C, this kind of a story was not writing so far, but 2 years ago were published the data from the Revolution study that was run in Taiwan. They include nearly 25,000 individuals followed for more than 16 years. Of them, more than 1,000 were seropositive for hepatitis C and viremic, 2/3 of the patients. And after this long-term follow-up, they compare strong endpoints, so death. And this is what happened. When you stratify the population comparing hepatitis C antibody positive versus the rest, followed for 16 years, as you expected, deaths were higher in hepatitis C seropositive individuals. And when you look at the causes of death, they were related with the liver as expected, but not only with the liver. They were also higher extrahepatic rates of death in this population, including cancers, cardiovascular risk, and kidney disease. The cancers more associated with hepatitis C seropositivity were in the esophagus, in the prostate, and in the thyroid. All these figures, what we call the hazard ratio, was significantly enhanced in viremic individuals, not those only seropositive, but with true chronic hepatitis C. So curing hepatitis C is not just curing a liver disease, you are doing something else. If we put the same table that in HIV, really, and we try to think about the cost-benefit of the very expensive antivirals we are discussing right now for hepatitis C, probably the figures for cost-effectiveness are moving in the benefit of treating almost everyone, like in HIV. So there is a contention of viral replication that translates in true eradication for hepatitis C, This is not the same story for hepatitis B or HIV. We control hepatitis B, HIV, but we cannot eradicate hepatitis B or HIV. A major clinical benefit is the regression of fibrosis, including cirrhosis. There is less persistent inflammation and immune activation. There is less transmission, and they are data coming from small cohorts of intravenous drug users in Australia or in Switzerland. And really, when there is no virus, all the story about less tolerability of the liver for other medications, any kind of medication, tuberculosis drugs, epileptic drugs, anything is improved when you remove the virus from the liver. So really, when we talk about hepatitis C, the problem is in the past, we don't have drugs. But now that we have very potent drugs, the benefit is very clear and move beyond the liver. These are data we just published in CID from our cohort of a little more than 1,000 patients followed with FibroScan and for longer than 8 years. And as you can see here, we follow these patients and we look at the incidence of liver decompensation events and death. And with this streak in here, and I think this is real life, this is outside clinical trials, is that when we compare over time the survival of patients with HIV monoinfection and those who have co-infection but achieve sustained virological response with treatment, the survival is the same. There is no difference in the compensation events, magic things in the liver that happens in people exposed to hepatitis in the past. It's the same than in monoinfection. On the other hand, for those that were not treated for any reason, ineligible for interferon, other problems, for some reason not treated, sometimes decision from the doctor, or those who failed therapy, the survival was compromised, and this increased over time for these patients. And the only considerations here outside hepatitis C is that Delta patients, there were those that had the poorest prognosis. So we don't have treatment for Delta, as you know. Thanks to God, this is a very small subset of patients, but really this is a very challenging population. Despite this convincing data that treatment of hepatitis in HIV provides a benefit to the patients, what happens in the reality? These are data presented at CROI from a group in San Diego. We are not talking about India or other places. This is San Diego, this is California. So they have a huge cohort, Dr. Lalo Cachet, of co-infected patients, 751. And what was the problem? The problem in California is that many of these co-infected patients, they were not referred to doctors more or less able to indicate treatment, to assess the patient for treatment. They were not referred. The other step is that even when they attend one-time that doctor, they were lost, they were missed. So, and they don't come again to fix an appointment to start therapy. And the other problem is once they were assessed for treatment, for multiple reasons, they have a barrier to be treated. And the barrier was social problems, alcohol abuse, probably ineligibility for interferon, neuropsychiatric conditions, uncontrolled age, so no undetectable viremia, low CD4 counts. But at the end, what happens is less than 5% of the total group of co-infected patients were treated and achieved sustained virological response. Less than 5%. So less than 1 in 20. So there is a lot of work to do, despite having good drugs. In the other extreme, I put data here from my hospital because I have the data, but what I understand is that in France has been one of the countries more proactive for hepatitis C in terms of screening and provision of treatment. And my understanding is that in contrast with the US or other European countries, 70% of all patients with chronic hepatitis C in France have been diagnosed. So this has nothing to do with the story in the US. In the US, as you know very well, the government has pushed a universal screening policy, especially for baby boomers, people born between 1945 and 1965, because they expect that many people undiagnosed will come up and begin diagnosed and will have access to treatment. This work has been done in France for nearly 2 decades right now. And in my hospital, in co-infected patients,
we have tried to be also very proactive providing treatment. The good thing is that we cure the nice ones. So genotype 3, no advanced fibrosis, very compliant patients, very high CD4 counts. And what happened right now is that the bad guys are alive with chronic hepatitis C. And here, for example, when we talk about interferon experience, what happens is that more than 40% have failed interferon riba. The genotype, we have a huge pool of genotype 1 and especially subtype 1A, which is the worst. Advanced fibrosis, more than half of the population, and the bad interleukin 28 allelic polymorphism is 70%. So really, these are the patients we will treat with the new antivirals. They are not the nice ones. The recent past, we just 3 years ago, the US approved boceprevir and telaprevir, and in the new guidelines, we will discuss a little bit later on, they are no longer recommended. So boceprevir and telaprevir are contraindicated right now. So just approved in some European countries, like in Italy. In Italy, boceprevir and telaprevir become available in January this year. So it's something just approved and no longer recommended. So the present. Sofosbuvir and simultaneous has been approved in the US. My understanding is that in Germany and in France, you have access to these medications. In my country, unfortunately, there was a decision to produce a committee they call prioritization committee for select who will be treated because the medication is very expensive. And the committee was appointed for a second time, and we are waiting. We are waiting after the summer. And they don't say yes or not. They say just wait. Okay, and in the meantime, the patients came to the clinic, and you say, okay, just we will repeat the fibroscan and the ultrasonography. This is the present. At the coming future, and this is happening very fast, we are moving to single tablet regimes, like in HIV, so Truvada, Kyvexa, Atripla, Epiplera, everything together, once a day. The data in co-infection. So these are all data already, just published, but already all data. So this is telaprevir in HIV phase 2 trial. So you see here the results, 74% versus 45%. And this is triple therapy. This is a challenging therapy. We participate in the trial, and really, it was very hard. Many of you are familiar with the use of telaprevir, and telaprevir is not the worst of these two first-generation PIs. So the drug is provided 3 times every day or 2 times every day, depending, 3 times BID for 3 months, and you complete 1 year with pigylated interferon and riba. So, and the sustainable virological results, so improving versus pigylated interferon, but really, this is not the magic treatment. So it's 3/4 of patients with genotype 1. So the cons of triple therapy and the reason why is no longer recommended are here summarized, but really the major problem is that we need to use interferon, and a huge proportion of patients are ineligible for interferon, and the other is side effects. Side effects makes these drugs really unhuman. The study with simultaneous. Simultaneous was mentioned by Dr. Fabian Zulén. So the advantage, what we call second wave first generation PIs, is that there are 2 properties of second wave first generation PIs, simultaneous and faldaprevir. They are provided once a day, so 1 pill once a day, so nothing compared with 4 pills every 8 hours for 6 months or 1 year as boceprevir. So once a day, 3 months, that's all. And the other advantage of second wave first generation PIs is that they don't have significant side effects, so very much well tolerated. So this is a different world. The price is more or less the same, in the range of 25,000, so which is significant and is quite expensive, but it's not the same thing that we will hear later on. So sustainable virological response using these drugs is 75% more or less, and the only advantage is that what we call response guide therapy, so becoming undetectable very soon, allows you to shorten the duration of treatment to 24 weeks, which makes more compelling, more attractive this regime with pigylated interferon and riba. With faldaprevir, the trial is Star-Verso. Boehringer submitted the track for approval to the FDA, and later on the company make a movement to just be removed from the hepatitis field. So the drug probably will be approved this year, but there is no longer commitment of Boehringer to stay in the hepatitis C field. So they just halted the development of the non-nucleoside. So the drug will be an orphan drug there to be combined with almost everything, probably much cheaper than the current other PIs, and still pending to be approved in the US and Europe. Not very much different compared to simepevir. The only thing is that all the story you heard about the polymorphism at position 80 in the protease looks like not applied to faldaprevir. So you don't need to test at baseline genotype 1A for this polymorphism before providing faldaprevir. You need to do that for simepevir, which really makes a barrier to use the drug. Sofosbuvir, we came for the magic drugs. The trial in co-infected patients with sofosbuvir has just been presented at CROI 3 months ago. So provided very nice data and very compelling, really. So looks like they are not much different from mono-infected patients. So one pill, along with almost everything in terms of antiretroviral therapy, provide rates of cure about 75% and in some instances around 90%. Sofosbuvir, ribavirin. That's all for 3 months. In terms of interactions with these, let's say, current new direct antivirals, for sofosbuvir, not relevant. There are a few interactions with tenofovir, something stories, but clinically significant, not relevant. For simepevir, they are. So it's a cytochrome P50 inducer, an inhibitor. So darunavir and atazanavir cannot be used with simepevir, and the same happens with efavirenz and nevirapine. With etravirenz and rilpivirine, there are some data that probably allows you to use these drugs. For faldaprevir, not really significant interactions. The drug is conjugated by the bilirubin system, by the UGT. And for daclatasvir, there are not many interactions, but you need some adjustments for efavirenz for a tripla and for atazanavir. So it really makes that some expert has to give the medication. So putting together the data we have for boceprevir, telaprevir, simepevir, and faldaprevir, the protease inhibitors, you can see here that really, despite there is improvement with respect to pegylated interferon and riba, we are far from the perfectist that was mentioned by Dr. Sulem. So it's 75%, 80% sustained virological response using 24 weeks or 48 weeks of treatment. With sofosbuvir, the nice and compelling history is that we don't use interferon. And just sofosbuvir ribavirin for 12 weeks, 24 weeks in cirrhotic genotype 3, null responders, prior null responders, probably improve the response rate and make more or less comparable, around 75-80%. They are lastly in co-infected patients, a report from Merck. Merck, that was the successor of Schering-Plough, a company that has been with interferon for 25 years. So they presented at CROI also this data combining a protease inhibitor, a real second-generation protease inhibitor, more or less pangenotypic activity, more resistance barrier, with an NS5A inhibitor. And these are the data, just 59 patients with co-infection. And magic. So they don't need ribavirin, at least in this study in non-cirrhotic patients. So more than 90% of the patients have reached sustained virological response. So just to take some smell of not just more than 90% results with almost everything, I just want to address at the end specific things that may make more attractive how to use these drugs in the current world. No? I will address the issues. One is a spontaneous cure of chronic hepatitis C in HIV carriers, treatment of active intravenous drug users and acute hepatitis C, mainly in homosexual men. We just published this paper in AIDS, and I am aware that there are cohorts in Sweden and in California, in San Diego, that they have almost the same data. And these are the data. We, looking retrospectively at our cohort of co-infected patients, we have the chance to check for longitudinal testing for hepatitis C in these patients. And we came with 6 individuals that, despite not being treated for hepatitis C, no interferon, no direct acting antivirals, they clear spontaneously viremia for hepatitis C. All of them were on antiretroviral therapy. Different genotypes, different viremia, different liver fibrosis, and the time to clearance of this viremia was, in sometimes, many years, several years. So it was a real chronic hepatitis C that, for some reason, was not a mistake, was not a laboratory failure or false positive. No, it was a real disappearance. And the interesting thing is that all of them have interleukin-28 CC, the nice genotype. The same results, as I mentioned to you, have been reproduced, I am aware, in Sweden and in California. This is a small subset of patients, but for us, the clinical implication is for those with co-infection that have been in our clinics for several years, before thinking in these new medications, you need to repeat viremia to be sure that still the virus is there. Because in some of these patients with very high CD4 counts, maybe the virus already vanished, especially if they were CC for interleukin-28B. Treatment of intravenous drug users. We were invited to write this editorial for Nature Gastroenterology. So as you are very much aware, there is some pressure, I will say in the nice words. So it is always good to treat someone with a disease, but you need to balance the whole benefit. You don't have a virus, you don't have a liver, you have a person with a liver and a virus. For an active drug addict, the most important problem is not hepatitis C. We may produce a wall. Oh, the virus is there, cirrhosis, transplantation, but the guy is in the garden. He's robbing, he don't have a job, and he may die from overdose. This is the reality. Some of these studies treating active drug addicts has been run in ideal places, a small green garden in Switzerland or a small place in Australia. But at least in my country, drug addicts are everywhere and the police is following them. So, treating hepatitis C is ideal, especially in drug addicts, active drug addicts, because we will stop transmission events, but at the end, we treat patients with hepatitis C, patients, humans, with a liver and the virus. So probably, if we want to help these guys, we need to provide first social environment to protect them from this behavior, and later on consider the illness, the medical complication. And hepatitis C, acute hepatitis C in homosexual men. France has a lot of experience, was one of the countries that reported the first outbreaks in Europe. We started later on, I don't know clearly why, but just over the last, let's say, 5 years, we started to see cases. This is the story in my hospital, 31 patients, almost everyone homosexual men, patients on regular follow-up in the clinic, so they have access to education, transmission, information. So, but this is what happens. So we have a huge outbreak of syphilis among homosexual men, along with or without acute hepatitis C. And so 10% of our homosexual patients with HIV, most of them with undetectable viremia for HIV, they suffer an episode of syphilis. And some of them have the episode, in addition, of acute hepatitis C. The viruses responsible were subtype 1A and genotype 4, and they were outbreaks, sometimes not direct outbreaks, so they don't know each other, but they were in the same network. So, we are moving in HIV, like in mono-infected patients, to these paradigms to test everyone, to treat hard and short, and to cure most people. Following the guidelines in mono-infected patients, I will not extend more, but I recommend you that you visit this website. This is updated in a real time, every day. So this is incredible. This is running very fast. And this is pushing the authorities to reflect in guidelines what people is doing in the real clinic and keeping legal off-label use of drugs. It was mentioned before by Professor Sulen. In the US right now, sofosbuvir and cimeprevir are widely used. It's very expensive, 100,000 euros, but cure almost everyone. The companies decided to switch off, so they will go separately, Gilead and Janssen. But people know that the data are very compelling. If the patient is compliant, almost everyone is cured. Interferon eligible. So you need to justify, the insurance companies will pay you when you justify that there is a contraindication for interferon. This is recorded in the guidelines, and this is the list. And some of the things are very objective, but other neuropsychiatric things and all these things are more subjective. And for a relative of me, if he has or she has chronic hepatitis C, really, I will not use interferon. This is for non-responders, very good results, more combinations, so plenty of options. And looking ahead, so co-infections really no longer matters because drug interactions really not very important with the new drugs. Everyone will be treated. And hepatitis C, in contrast with monoinfection, probably will be kept by HIV doctors. Different story in monoinfection. These are the new single tablet regimes that are coming on. 3 years, no more than that. This is running very fast. So like in HIV, so Truvada, Atripla, Kyvexa, the combination that will came with dolutegravir and Kyvexa. So we are moving in the same pace. Looking at the companies, so which is interesting here, that the classical ones, Roche, Boehringer, even Merck, are vanishing. And the good ones are Gilead, AbbVie, and BMS. Who will treat in monoinfected patients, as I mentioned? Things are moving like, maybe I am wrong, but this is my feeling. In 5 years, everything will be very easy. It's like Helicobacter pylori. In the past, we refer to an endoscopist, to a gastroenterologist, they do the biopsy, they check everything for Helicobacter pylori, and at the end, what you do? You provide treatment for 1 week with clarithromycin and amoxicillin or metronidazole. Everyone is cured. You no longer perform a second endoscopy to prove that it's cured. You have symptoms? No, it's okay. Make a urea breath test. That's easy. You fail, you are retreated. What else? So, and the same will happen with hepatitis C, my feeling, in mono-infected patients. So, at the end, there are not much differences. So probably general practitioners will be more and more involved in the treatment of hepatitis C. After, what do you want? 5, 7 years? That's all. But in co-infection, because HIV is there, probably the responsibles will continue to be us. And I will finish here. Thank you.
Thank you very much, Vincent, for this very exhaustive and comprehensive presentation, and also provocative slide. That, so right now the session is open for discussion. We have just time for 1 or 2 questions. So Vincent, we have a French paradox that, as you know, we are doing some drug concentration and plasma measurement, especially for co-infected people. And we know, for example, with the Cimeprevir and Daclazazvir, that there are also some drug-drug interaction. And do you mean that we have to measure also in this patient the plasma drug exposure? What do you think? Do you have any experience in Spain? Do you have some experience about it?
Philip, I think maybe from the academic point of view, checking plasma levels of Cimeprevir and Daclazazvir makes sense to discharge that significant clinical drug interactions may occur and explain failures. But in reality, the story in HIV is that despite you have the means, it's not very expensive making therapeutic drug monitoring. In the reality, because there are plenty of therapeutic options, we no longer, outside academic purposes, we no longer go to the clinic with plasma levels. So we rely this data for the companies, and if they say that we improve Daclazazvir levels using efavirenz, for example, we believe that and we follow that. I think that when you use drugs for only a strict period, 3 months, all the issues of drug interactions become less important because you can play with the co-medications. A different story with longer treatment, long length of therapies. No? When you used to use rifampicin with antiretrovirals for 9 months, for example, that's a different story. But here, you can play, and like with Telaprevir and Boceprevir, I am sure you did that, everyone was moved to Raltegravir just to avoid problems.
Yeah. Yes.
Yes, Vicente, fantastic talk. I agree with you that everything is going to be simple and that GP could maybe treat all patients. However, the thing is that we need to keep in mind that if we cure the virus, we are not going to cure always the liver. So I think that for hepatologists, the future will still be there, because we have there to look after the liver evolutions of the disease and the regressions of fibrosis. And there is some unknown point actually on the future and the risk of hepatocellular carcinoma, which is still remaining or not after we have cured the virus. So I think that it's true that everything is going to be more simple. We are going to cure almost all patients in terms of HIV, but liver disease will still remain a problem. Are you agree with that?
Yes, Mark, I think you make an important point. So, despite curing these patients, those with advanced fibrosis, mainly cirrhotics, they need to be followed every 6 months, every year, like in infected people, because the risk of hepatocellular carcinoma, as you mentioned especially, is there. So cirrhotics, they need to stay on follow-up for long periods after being cured just to control this risk. You're right, Mark, I agree. Mm-hmm.
Yes, thank you, Vicente, for this very nice presentation. Also, one very short question on, do you know if there are any data in the HIV co-infected patients regarding this residual risk of HCC in patients who have cured HCV infection? Is it the same as in non-HIV patients? Do you know, is there data around or not? And so that's the first question. And the second one is on ribavirin. Do you think that in HIV co-infected patients we would still need ribavirin?
I think both points are important. So the second question, so I think that for HIV with good control of replication, the behavior is more or less like in mono-infected patients. And really, if we can, we will move off ribavirin, really. Very clear. And with respect to residual replication or virus in co-infected patients more than in mono-infected patients, as you are aware, there have been some publications, some of them very, I would say, enthusiastic about residual viremia in co-infected patients because immunosuppression. But in the reality, there are many other reports that have not confirmed that. And our own little experience is that once you have sustained virological response in co-infection, more or less translating cure like in mono-infected patients. All these issues of late relapse, and we have published several late relapse, in fact, this was the question I had to you before, it's like in mono-infected patients. So for some reason, in some patients, despite undetectable viremia, without therapy, the virus may reappear. The same virus is not a reinfection. And so we need to explain why the virus was hidden or staying with very low replication there. But I don't recognize a special behavior in co-infected patients. That's my answer.
Thank you very much, Vincent, for this nice presentation. So it's a great pleasure to have our local French hepatologist, Dr. Marc Bourlier. He's the chief of the liver disease in the Hospital Saint-Joseph, and also the chief of the French branch AC24 on the French Agency Against AIDS. So before you start, Marc, I have just a question. Is there any place for interferon treatment?
Well, I think that after listening to Fabien and Vicente, the answer is clear, a very small place. And I think that you have already evidence that HCV can be cured without interferon. So first of all, I would like to thank Alain Lafeuillade and the organizing committee for the kind invitations. And this is my disclosure. And so, as already mentioned by Fabien, interestingly, there is a huge development of different multiple class of molecules for HCV treatments in the last 5 years. And comparing to HIV, the interesting thing was that all these drugs were developed simultaneously. And so therefore, we were able to have all these drugs on the market at about the same time. So comparing to the HIV stories, everything was more done in a small time period. So actually, I will just focus my slide in order not to repeat what Fabien has already said on what is really available on today and this year and next year. So this year in Europe, sofosbuvir, cimeprevir, and daclitazvir has been approved by the European authorities. However, it's interesting because the approval of drug is given on a European basis. The access to the drug is completely different according to country. And I think France for that is very lucky because France is the only European country in which the patients with most advanced disease are able to receive almost 3 drugs, sofosbuvir, cimeprevir, and daclitazvir. If you look at the Spanish situation, which has been described by Vicente, there is only a few options for patients for sofosbuvir, but in a very restricted way. In England, for example, sofosbuvir is only available for 500 patients F4 in additions with, in combinations with daclitazvir or ledipasvir for this year. And in Germany, sofosbuvir is given in a very simple way to almost every patient within the label. However, the recent German ad hoc committees like the NICE committee in England decide that the data on sofosbuvir was not so good, and so there are some discussions about the price of the drug. So the access to the drugs are very heterogeneous according to country. So if we look now genotype by genotype, according to what we have in France, sofosbuvir, cimeprevir, and daclitazvir, there is evidence now that in genotype 1 patients treatment naive, you can treat patients with an interferon-free regimen on the right part of the slide. And you can see that with an association of sofosbuvir and cimeprevir, or sofosbuvir plus daclitazvir, you are able to reach more than 90% of SVR. If you use only sofosbuvir and ribavirin, you are not on an optimal regimen, and this regimen should not be used because we have more potent regimens. When we move to treatment experienced genotype 1 patients, again, you see that the associations of sofosbuvir and cimeprevir is able to reach a very high rate of SVR in null responder. And interestingly, in this Cosmos trial, you can see that whether you are using ribavirin or without ribavirin, the SVR rate is the same. They also demonstrate that 12 weeks is the same as 24 weeks. And more interestingly, you know that with cimeprevir, there was a question about the Q80K mutations at baseline that leads to a less SVR. But when you are combining cimeprevir with sofosbuvir, this impact of Q80K appears to be very less important, and therefore you can combine it without any problems. And when you move to the first generation PI failure, those who fell on telaprevir and boceprevir, we have already now, we know that we can use sofosbuvir and daclitazvir, and the result on those patients treated for 24 weeks were between 95 and 100%. So very good result here again, with or without ribavirin. You see that the ribavirin's role is really minor in this setting, and we don't need to have ribavirin in these populations. So this is reflected in the European guideline that I recently published in the after the last EASL meeting. And you can see that for genotype 1, the options 5 and 6 are really interferon-free option regimens, 12 weeks, with a very high rate of SVR. So if we move to genotype 2 patients are really patients that are able to be cured with the only use of sofosbuvir and ribavirin. And clearly you can see, coming from the phase 3 study, that either in naive patients, in intolerant patients, or even in non-responder, we are able to reach more than 90% of SVR. The only problem with genotype 2 is those patients who are genotype 2 non-responder and cirrhotic. And in this case, if you are doing just a 12-week regimen, your SVR rate will be only 60%. You can move up to 78% when you do 16 weeks of treatment. So therefore, in these special populations of genotype 2 non-responder cirrhotics, you can ask yourself if you can maybe prolong the durations of therapy. And that was one of the proposals due by the EASL guideline. The other thing that if you fail and if you relapse, in fact, for these patients, you can maybe use, again, either a longer durations of treatment, so sofosbuvir, ribavirin for 24 weeks, or you can use a triple regimen with PEG and RIBA. And you can see in this study recently presented by Rafael Esteban that if you use triple regimen in this setting of those people who relapse after a first treatment with sofosbuvir, you can reach 100% of SVR. So this is very encouraging result in this setting. And the most important thing is that with this example, you see that when you use sofosbuvir and when your patients relapse, you can reuse after sofosbuvir in another combinations and be able to reach a very high SVR rate. The other options for genotype 2 in this setting will be also to use sofosbuvir plus another NS5A like daclatasvir or even simultaneous, the protease inhibitor, because we know they are active against genotype 2. For genotype 3, you see that using only sofosbuvir and ribavirin is not the optimal solutions. However, the result that we've got is exactly the same we've got with PEG and RIBA, but the safety are completely different and the treatment is more safe. So sofosbuvir plus ribavirin for 12 weeks lead to about 60% of SVR in genotype 3 naive patients. So clearly the good durations of treatments appears to be 24 weeks, and in this setting sofosbuvir plus ribavirin 24 weeks leads to 92% SVR rate in naive cirrhotic patients and 60% in non-responder cirrhotic. So again, in cirrhotic patients, G3 non-responder, these populations are not optimally cured by these regimens, and we need other regimens. So we can again move to a triple regimen with sofosbuvir, PEG, and RIBA, and that was done also in the same study that I already previously presented to you. And in this case, you are able to reach, even in cirrhotic or non-cirrhotic patients, over around 90% of SVR. So this is another option. But interestingly, you can see also that in these populations, if you are treating patients who have failed or relapsed after, not failed, but relapsed after 12 weeks of treatment, treating them 24 weeks can lead to a substantial SVR rate in these populations among non-cirrhotic patients. The other options will be maybe to use the combinations of sofosbuvir and daclatasvir. However, as already mentioned by Vincent, in these populations we have data on naive patients but not data on treatment experienced patients. These data are now going to be made by our own clinical practice, and that's the other objective of another QPIC trial that we are going to lead in France in order to get all these informations back and give the results. And you can see that in naive patients, the associations of sofosbuvir and daclatasvir lead to a very substantial and high SVR rate for 24 weeks of treatment. So when we move to genotype 4, clearly again the use of sofosbuvir plus ribavirin alone for 24 weeks lead to a very high rate of SVR. You are able to reach 79% of in naive patients and 87% in non-responsive patients. So that's the rate for 24 weeks, 100% for naive, 87% for non-responder. So again, here you are able to cure patients without interferon. And there are other options that are actually currently studied, but for which we have no real data actually, but we know that simultaneous and daclatasvir are active in genotype 4 patients, so therefore combinations of simultaneous and sofosbuvir for 12 weeks or combinations of sofosbuvir and daclatasvir for 12 weeks is an option in these populations. So this is reflects in guidelines, and here is the recommendations from the French associations that have been put it for these last versions yesterday on the websites. And you can see that whatever you consider, genotypes you consider, you have an interferon-free options for all your patients, naive, relapser, or non-responder, whether you are dealing with genotype 1A, 1B, 2, 3, 4, or even 5 and 6. For most of them, we have data, but in some of them, we have no data, but we know that theoretically, this regimen is working. So beyond these 2014's regimens, we are going to have more drugs in 2015. And as already mentioned by Fabien, in 2015 we are going to have at our disposals the combinations of sofosbuvir ledipasvir, so NS5B nuke plus NS5A, and the triple combinations from Abbott with the protease inhibitor, the NS5A, the NS5B non-nuke compound plus ribavirin, and the associations from BMS with azunaprevir, daclatazvir, and the BMS 325. So that will be new result, and I just will go very fast through the results. And as already mentioned by Fabien, with this kind of regimen, with sofosbuvir, ledipasvir in genotype 1 patients, whether you are naive treatment experience and with 20% of cirrhotic patients, you are able to reach always more than 90% of SVR. And again, you can see with this data that we can treat patients with a short durations of treatment, 12 weeks, and without ribavirin. And the only exception, as mentioned already by Fabien, is the populations of cirrhotic experienced patients in which longer durations of treatment may be and may have an advantage, and for which the use of ribavirins may be discussed. So as you can see with all this data, the place for ribavirin is really being less and less important, and the durations of treatment is only a problem for the most advanced patients. Same data coming from Merck, and again with the second generation protease inhibitors plus a second generation NS5A, with again a very good result in all populations where the patients are naive, treatment experienced, cirrhotic or non-cirrhotic. And the same experience with the Abbott study with the 3 DA combinations. So 3 DA combinations may appear to you as a huge number of drugs. But I think one thing will be important in the future is to look after the safety profile of all these compounds. And for example, the triple combinations of AbbVie, like the Merck combinations, they are very well supported for the patients. And for the first time, we were able to demonstrate, and that was done with the sofosbuvir study, that we improved the quality of life and the fatigue scale during treatment. And that's completely new for us, because before, whatever you use, and when you use even ribavirin, in this case your quality of life is always declining during treatment, and now the quality of life is improving even during treatment. So this is going to be, and to make maybe the difference between those drugs. And again, here the results are very impressive, and even among the cirrhotic patients. And you can see that in the large set of cirrhotic patients, more than around 400 patients, you can see that they were able to reach either in naive or treatment experienced patients a very high rate of SVR. So if we pull that together and look at the result among, for example, cirrhotic patients in naive patients, you see that we are able with all these combinations to reach more than 90% of SVR. And the same is true with treatment-experienced cirrhotic patients. So again, for those patients who are the most difficult to treat, we are able to reach the goal of being cured with interferon-free treatments. These treatments are also working and moving forwards for even other genotypes, as genotype 4, and again with the combinations of the protease inhibitor for AbbVie with the NS5A inhibitors for 12 weeks, we reach around 100% of success among naive or treatment-experienced patients when you use ribavirin. But if you don't use ribavirin, you still have 91% of success, which is very impressive. So the next point and the next things will be to move to new drugs, and I was already mentioned by Fabien, when you use the second generation's NS5A with a more potent pangenotypic profile, you are able to cure almost all your genotypes. And you can imagine with such a regimen that in the near future, in fact, genotype will be of no need or no matter if you are able to have a fixed combination. So if we look at the future could be like that. Either we are going to have treatments which have been driven by the genotype, and we could have different treatments according to genotype with different durations, always short, between 12 weeks and maybe 8 weeks, with only longer durations for the most advanced patients with fibrosis. So the treatments will be driven by genotype and fibrosis stage. Or even we are able to have really good pangenotypic combinations, and in this case, we could have treatments which can be used in all genotypes with a fixed or a variable durations of treatments according to fibrosis stage, for example. So clearly, in the future of 5 years, I will say that the place of PEG interference will be something like, I put less than 5%, not to put 0, but I think because you could never put 0 for anything, but I think that the place will be very, very small. Treatment durations, 12 weeks is really now one of the main durations that we have. We can discuss to going shorter to 8 weeks, but I think that's maybe me restricted to a very small subset of the populations. And I would think that the whole populations will be maybe treated for 12 weeks. And we will reach about 100% of SVR. So we are going to cure HCV, yes, but not the liver disease. And this is a very crucial point. I mean, we are dealing with hepatitis, and we are dealing with cirrhosis and hepatocellular carcinoma. So even when we are curing our patients can have a progression of fibrosis due to overweight, alcohol, and other cofactors. And I think we need to keep that in mind and always make the follow-up of our patients in order to avoid the occurrence of the complications. And there is another point which is still remain a question, is whether or not the fact that you have HCV for a certain period of time among your liver, how it can induce any hepatocellular carcinoma mechanisms. And that's the thing that we need to study in the future, because we have actually not the answer. So clearly, chronic HCV infections can be cured with all these combinations, but there is still challenge, as already said by Fabien and by Vincente. We know that older age is not a problem. Polypharmacology may be a problem, but we have seen that with some drug we can avoid this problem. Advanced disease, Fabien showed you that we are able to cure patients with interferon-free. Intravenous drug user, we can do it, but that's all the problems that have been addressed by Vincente. The adherence challenge will be a problem, and that's really why I think it's important to follow our patients. It's important to still do HCV RNA monitoring during treatments, because it's the way we can also challenge the adherence to treatments. We are going to fail with some patients who are going to be non-adherent to treatments and therefore can develop some mutations, and especially more complex mutations. However, the result that we have with sofosbuvir is quite reassuring in this issue, because we know that we can research them. And the main problem will be to diagnose more patients. So maybe this illness is going to move from hepatologist to GP, but the thing is we need to screen more patients, because actually with PEG and RIBA, among 100 patients, among the whole populations of HCV patients, according to country to country, we have diagnosed only maybe 40% of the populations in the country in which the screening was the best. But it's moved from 20 to 40%. And in this case, if you are able to cure only 50% of the populations, you are going to cure only 10% of your HCV populations. When we are moving with higher regimens now, if you do the same screening policy, you are going to cure only 19% of your populations. So the key point is really to increase diagnosis and to increase the screening. So the screening policies is something that we are really need to focus, and there is different screening policies according to country. For example, the US developed the baby boomer screening policies, but we know that in Spain, this policies is not the good one. We know in Spain we need to look after patients who are maybe older, because it is a population in which the prevalence is higher. And in France, last Monday, we have presented at the French Ministry of Health the HCV report, and the recommendations from this report is to screen all male from 18 to 60 years. And apart the usual screening that we are doing. So that was the recommendations that was given to the government. As we have already discussed yesterday, given a recommendation is one thing. Making it a reality is another thing. So that's, you need to input some funding in order to do this screening. You have to input rapid diagnostic testing and a lot of things. So this is a policy that we have to change, but this is crucial in order to increase the number of patients that we are able to cure, and if we want to somewhere try to eradicate the disease. Thank you very much for your attention.
Mark, thank you very much for this very exciting, nice presentation with a great overview of all the treatments. So we understand that the resting place of the interferon on the future is less than 5%, if we understand correctly your last slide. I have a question about...
in France, I think we have always to keep that in mind. I mean, in a lot of countries worldwide, the only access to treatment is PEG and RIBA. And despite the approval, Russia has just have Telaprevir and Boceprevir for less than 6 months. And a lot of Eastern European countries have just access to Telaprevir and Boceprevir in the last year. So despite an approval in 2011, even in the European Union, there is a huge discrepancy on access to the drugs according to country to country.
So we know that in France we are very lucky about the drugs that are available right now. But regarding the costs of these drugs, and for example, if we combine Sofosbuvir with Daclazavir, it's approximately 100,000 euros. Do you mean that because the treatment regimen and the period is fixed, do you mean that we can imagine how we can shorten the treatment to save costs without affect the SVR? Do you mean that with a rapid virological response in certain patients, we can maybe shorten some treatment? And the second question that I have for you, we have right now available the Simultaneous and the Daclazavir in ATU from French cohort and after available in the market. What will be your criteria of choice between the combination between Sofosbuvir plus Daclazavir or Sofosbuvir plus Simultaneous?
So there is 2 points. The first point is the cost of the molecule and the cost of the combinations. And I think that we have to say that actually we have not exactly the fixed price of all those combinations, and this is still in discussions. That's why there is all the discussions around Europe regarding the Health Authority about the cost of the drugs. The second thing is that even if the cost of the drug is between 30,000 or 50,000 euros for a full treatment, for a cure, the problem is still remaining. And the attitude, for example, if you look at the EASL guideline, is that if you see the difference between treating patients, for example, 12 weeks and 24 weeks, it's only 20% difference. And that with 12-week treatments, you are able to treat 80% and to cure 80% of your populations. In terms of economic cost, the good thing is to go first on the short durations of treatments and then use the longer durations for those who failed. So it's a different approach. And that's an approach that has been taken by a lot of European experts. And that's why it was also defended into the EASL guideline. So I think that they may have huge discussions when they are writing the guidelines about this point, is whether or not, for example, if you already reach 80% when you treat your patients 12 weeks, why are you going to over-treat 80% of your populations within 24 regimens? So you can just go for 12-week treatments, and those who relapse, you then retreat them with longer durations of treatment or with other combinations. So the questions for this attitude was if you really induce high resistance mutants, in this case you may have some problems in order to choose the drugs that you are going to use as a second treatment choice. The result that we have recently presented with Sofosbuvir are quite reassuring when you are using Sofosbuvir as a backbone. But you have to keep in mind that it's not the case, for example, for the NS5A resistance or for the NA3 resistance, the protease inhibitors resistance. And actually, we need to have more works done about the behavior of this resistance in the future and how they would impact the response on retreatments. So for this point, there is still points which have non-answered questions. So that's for the first questions. Yeah. And for the second question, whether I am going to choose Simultaneous and Daclazavir in association with Sofosbuvir. First, there is some populations for which we have data, so I always prefer to choose a proposal in which I have data. But I think there is no major difference between those two drugs in terms of safety issue. The only side effect with Simultaneous is sometimes this photosensitivity effect that you have to be aware of, and it's important to remind to patients that when they are using Simultaneous, they may be aware of the photosensitivity and they took cream in order to avoid this photosensitivity. But that's the only point in terms of safety issue. Otherwise, the associations of Sofosbuvir and Simultaneous or Sofosbuvir and Cladazir are very well tolerated by the patients. So it's no real.
In the interferon-free regimen, do you mean that there is still a recommendation to screen the Q80K before treatment or not?
I think that the Cosmos data suggest, but I say suggest because you have to look at the number of patients involved in the Cosmos data, which is very small number. But the Cosmos data suggest that the implications of the Q80K mutations when you are dealing with combinations is less important. And therefore, the recommendations that was initially done and given to screen patients for the, not the mutations, for the Q80K, I would say it's not a mutation, it's polymorphisms, was important when you are dealing with Cimeprevir, PEG, and Riba. When you are moving to these DA combinations, it's no importance. And the recommendations given by the French agency 2 weeks ago was not to do it when you are doing it in a combinations of DA regimens.
Thank you very much, Marc, for this very exhaustive presentation.
Thank you.
So we would finish the session by two oral communications. The first one is presented by Moana Gelou-Siméon of Villejuif's Paul Brousse Hospital. She would remind us to the reality of the present by the carcinovic cohort and report the prognostic factors of deaths in HIV and HCV co-infected patients with hepatocellular carcinoma.
Ladies and gentlemen, Chairman, I present you the prognostic factors of death in HIV-HCV co-infected patients with hepatocellular carcinoma and the results from cohort carcinovics. My disclosures. Currently, as we mentioned before, there is an increasing incidence of HCC in HIV-infected patients. It has been also reported that survival of HIV-HCV co-infected patients with HCC is globally poorer than HIV-negative patients. The aim of this study was then to define, in HIV-HCV co-infected patients with HCC, their demographic characteristics, prognosis factors, and survival. We conducted the carcinovic cohort from 3 NOS multicentric prospective studies, and these studies are still ongoing. The first one is PRETEVIC study, which started in 2009 and is evaluating the outcome of HIV-HCV co-infected patients with end-stage liver disease. The second one is EPAVI study, which started in 2005 and also evaluating the outcome of HIV-HCV co-infected patients with or without cirrhosis. And the third one is severe cohort, which is evaluating the outcome of HCV or HBV cirrhosis. From the two first cohorts, 50 HIV-HCV co-infected patients with HCC have been diagnosed, and 50 others HCV monoinfective from the severe cohort. The diagnosis of HCC was based on vascular imaging according to ASLD criteria, and from this date, patients were followed up every 3 months until liver transplantation or death. Clinical, biological, and radiological data were collected. This is a national study, and 19 centers participated in the study in France. The epidemiological features of these 50 HIV-HCV infected patients with HCC were a majority of young male, infected through intravenous drug using, but also the HCV genotype was 1A in 34%, and these patients were well controlled by a combined antiviral therapy in 97%. Concerning the cirrhosis, the state of cirrhosis, the SHEID-A score was the score in 60%. However, you can see that a previous decompensation has been documented for this patient in 63%. In 74% of these patients, pegrebavirin have been initiated, but unfortunately, 70% of these patients had non-response. Concerning the features of HCC now, alpha fetoprotein was 20.4, and this HCC have been diagnosed through a regular follow-up in 75%. The diagnostic method was CT or MRI, and at presentation, the imaging presentation was a nodular form in 76% and an infiltrative form in 24%. This tumor was accompanied with a venous portal thrombosis in 30%, and this venous portal thrombosis was tumoral in 93%. Here is represented of an infiltrative type of HCC with malignant portal thrombosis. In slide A, you can see the arterial phase, the infiltration, and the washout in portal phase associated with the tumor portal thrombosis. 3 factors have been diagnosed associated with survival, which influence survival. The first one was portal thrombosis. As you can see, 70% survival at 2 years was found for patients without portal thrombosis against 10% for patients with portal thrombosis. The second one was infiltrative type of the tumor with a 68% survival rate at 2 years for patients with a nodular form at diagnosis. However, for patients with an infiltrative form at diagnosis, no patients were still alive at 2 years. And the third factor was prior decompensation with a 60% for patient, 60% survival for patients without prior decompensation against 26% survival at 2 years for patients with a previous decompensation before the diagnosis of HCC. Using a multivariate analysis, these factors were also associated with survival, and the risk of death varied from 6.9 to 12.3, depending on the existence of previous decompensation, infiltrative type of HCC, or venous portal thrombosis. In conclusion, survival of HCV co-infected patients with hepatocellular carcinoma is significantly impacted by cirrhosis decompensation and infiltrative tumor with portal thrombosis, and this result suggests that new screening guidelines of hepatocellular carcinoma is needed in this subgroup of patients. Thank you for your attention.
Thank you. Is there any question?
Yes, I have a question. What do you mean about a new screening that we can imagine for to try to make an early diagnosis in these patients, or maybe new recommendation, or maybe different follow-up of these patients? What do you mean?
Yes. I think these patients, the problem is not to detect a nodule in these patients. The problem is the aggressiveness of the HCC in these patients. And more rapidly we can detect the nodule, more it will be benefit for the patient. then we can propose different guidelines. Maybe the screening interval is not sufficient, but I don't think it's a good thing to do. Just follow the EASL guidelines would be a good thing. That means for patients with a nodule, when you detect a small nodule less than 2 centimeters, don't hesitate to do scan or MRI rapidly. And if the diagnosis is not sure, don't hesitate to biopsy it. I think it would be a good guidelines for these patients.
And there's a lot of discussion about how we can shorten the screening using the ultrasound and alpha-fetoprotein every 3 months in this patient instead of 6 months. But do you mean that we have some advantage in terms of cost benefits of this strategy?
If we base on the reports of Dr. Trinchet and collaborators, in HCV monoinfected patients, the survival was not improved by shorter screening, a shorter screening interval. So the same study should be made in HIV-HCV population, but if we base on these results, there is no benefit to short the screening interval. You can, with shortening this screening interval, will conduct to detect smaller nodules, but if we don't know what to do with these nodules, there is no gain for survival.
Microphone number 3, Marc Bolia.
Yes, wonderful presentation. Following this point, I think it's very important to try to put a new study on that, because actually everybody have in mind the result of Jean-Claude Trinchet's study regarding the fact that doing more than every 6 months is unuseful. However, for the co-infected patients, we have really new data, and small data coming from non-French group, but from other European group, or I think American group, sometimes suggest that we can discuss a shorter period interval. So I think there is really a need for making a new study on this setting of co-infected patients regarding the incidence and the importance of the screening and the timing of the screening.
Effectively, I think the problem is not to detect the nodule, but what to do when we have the nodule. Because we have to keep in mind that these patients have a more rapid than HCV monoinfective, more rapid evolution for HCC.
So that's a new job for the Barcelona group, is to make a new classifications and a new guidelines and recommendations for the HCC management in these patients.
Okay.
Thank you very much.
Okay, thank you. No more questions? Okay. So, okay. Okay, thanks for coming. Have a good day.